Let's call the June 2017 meeting of the Board of Health for the Spokane Regional Health District to order. We have a quorum for action today, so let's begin with a roll call, starting with Lori Kinnear.
Lori Kinnear, City of Spokane.
Bob Lutz, Health Officer.
Tony Smith, Spokane Regional Health District.
Susan Boyson, appointed member.
Chuck Hafner, appointed member.
Kevin Freeman, City of Millwood.
Josh Kearns, Spokane County.
Mike Munch, City of Spokane Valley.
Michelle Fossum, Legal Counsel.
And His Noble Recording Secretary.
Thank you all. Next on our agenda is our time for citizen input. We have four speakers today. We ask that our speakers limit themselves to 3 minutes, and please state their name and address for the record. First up, we have Becky Somerville. Somerville? Somerville. S-O.
It's my right.
Sorry.
Someone just came.
It's a long name, so it's hard to fit in there. Is this where I'm supposed to be? Yes. I've never been here before, so. Thanks. My name is Becky Somerville, and my address is 2215 West Carlisle Avenue, Spokane, Washington, 99205. I'm here today to talk to you about, sorry, I just am nervous, and the recent school exclusions. My children were affected by the exclusions. My high school students are here, and they're going to share with you today. They missed 2 months of school this year because we did not have our MMR vaccine. Sorry, I'm going to pull it together and read. So I was just looking over your bylaws for the Board of Health, because I feel like the word health isn't just limited to our physical health. So as the Board of Health, you're commissioned in your bylaws to supervise all matters pertaining to the preservation and life and health of the citizens in your jurisdiction. I would like to state that I don't think this is being done. My children's lives and health have been impacted very negatively by the recent decision of the health department officials to exclude them from school. When I think about health, it is not just our physical, but our emotional, spiritual, and mental health. My children, as well as others that have been excluded from school, have not been a concern. These kids have suffered, their privacy has been invaded, and the HIPAA protection that we all are supposed to be afforded has been robbed from them. They've been mocked by their peers and made fun of. They have been bullied by peers and ignorant friends and teachers. We've even had teachers bully my son. He had to leave a class. And their futures have been put on the line. I appreciate your position is to protect everyone from what you apparently believe is a threat. But if this is true, why just school? How far should we take it? Why not lock every unvaxxed person up during any outbreak? Because what if we go to the grocery store? What if we go to Walmart or Costco? We could be putting hundreds at risk. And what about those of us who choose not to get a flu shot? What about the threat we are to the public? Should we be excluded? Should we not go to work during flu season? What's our goal here? To create a healthier society, healthier children? Would you step back for a minute and look around? Do you think we're doing that? If vaccines are amazing and life-saving, shouldn't we have healthier kids? They might not be getting sick with the current diseases that we're immunizing for, but they're definitely not healthier. In the past, there's been other outbreaks without exclusion, and there was no public outcry. I believe most families with fully vaxxed kids are not concerned when they hear of an outbreak because they believe their kids are safe. My hope is we can do better next time there's an outbreak, and we all know there will be. Thank you.
Thank you. Next up, we have Hannah Somerville.
Hi, I'm Hannah Somerville, and my address is 2215 West Carlisle Avenue, Spokane, Washington, 99205. I'm Hannah Somerville, and I will be a junior at North Central High School. I'm here to talk about the school exclusions, and I would just like to say that it's not fair for someone who's worked so hard for their grades to be excluded from something that is supposed to be provided for everyone, because I was labeled as a dangerous person. I'm not a threat. The statistics speak for themselves. My dad works at a local university where I have free tuition, but I may no longer have the chance to get into that university because my grades have suffered so much. My A's turned into C's and my B's turned into D's. I was required to take finals and I had no idea what the material was on. And you can see that in my grades. And on top of all the academic work that I've missed, I was told I couldn't participate in a cooking competition that I had worked for months on. And I was not able to go to the huge school event that happens every year, Groovy Shoes. Even though anyone walking on the street could come in and buy a ticket unvaxxed or vaccinated. It is not fair for someone who's just trying to get an education to lose all of that. Just maybe take a second in the future and really think about the people's lives and possibly futures that you guys are impacting. Thank you.
Thank you very much. Next we have Jonah Somerville.
My name is Jonah Somerville. I live with my address 2215 West Carnell Avenue in the city of Spokane, Washington, and my zip code is 99205. I will be a junior at North Central High School next year, and I suffered through a total of 8 weeks of exclusion from school this last year. When I returned to school, my peers knew that I was excluded and started to make fun of me and my beliefs, and I felt like my privacy had been violated. I started to fall behind in my classes, and I had missed a lot of essential material. I even had one teacher who was essentially bullying me because she did not like the fact that I was not vaccinated, and I had to drop her class. I struggle with attention issues and stress with school, and the exclusions didn't make that any better. They added more stress and made me lose hope in catching up with my work, and I started feeling very depressed to the limit of having suicidal thoughts. I talked to my counselors and peers, well, not peers, parents, and got through my depression and was dealing with it, and then the second exclusion came along. At that point, I was told I might not go back to school before summer, and I gave up on fixing my grades. I came back to school, and I tried really hard to catch up to improve my grades. But my grades definitely suffered from the exclusions. I don't believe that I'm a bigger threat to public health and my peers, and I would like you to think about me and my life and education next time there's an exclusion. Thank you.
Thank you. Sorry. Next we have Karen Bontregan. I'm sorry if I mispronounced that. Karen? Oh, so you don't wish to speak? That's all right. Thank you very much. So that actually concludes our public speaking for today. Next up is our chair report. One of the things you may notice on the agenda today is that we have changed the quote-unquote administrator report to an agency report, and under that agency report will be contained any of our agency reports, the health officer, the administrator, our legislative update, and our comptroller update. So as is necessary, the administrator will lead that, and we will more than likely always hear from the administrator and the health officer, but it makes for a cleaner report during the on the agenda. Also, the exec board is currently working through a citizen, appointing the new citizen at large to replace Dr. Lutz. We're looking at how we want to work with candidates on that. As some of you are aware, those candidates are appointed by the county commissioners. Mr. Kearns and Mr. French are hopefully in consultation on that. If not, I think it's Mr. French's turn to lead that anyway. So I am speaking with Mr. French on that issue. And I need to have a general discussion or indication of Board of Health members who may or may not be present at the July 27th meeting. Specifically, do we have enough folks to have a quorum? We can look out. Lori, are you thinking you're going to be around? Thank you.
Yes.
Excellent.
I will not be.
Susan will not be here. Mr. Hafner?
I'll be here.
Mr. Kearns?
Yeah.
Okay. Mr. Munch? And I think, so that would, if we can get Karen and Sam, and Brian, that would give us a quorum for action, but at least with the people polled here, we would have a quorum for the meeting, correct? Yeah, so is there any point at 5 having a meeting? We just can't take any action. We can't take any action. So if we can pull one more together. Our mystery member. All right, so we will work on that and we will keep folks updated, but it sounds like getting one of our other 3 or 4 members here, we should be able to pull together a meeting for July. So at that point, the chair has nothing further to report, and we move on to Attorney Smith and the agency report.
Thank you. We'll start the agency report with the health officer's report.
And over the next couple of months, what I'll do is I'll touch base a little bit more in depth on all of those, and then, again, subsequently, I'll have other information for you in that regard. But really, the substance of my report today is really a segue on looking at the issue of suicide. And I want to emphasize that it's not just suicide in the teenage population, which we know is at crisis levels, but the reality is that we are looking at a crisis of suicide at all age levels. Hello. Okay, so back in 2001, the agency was able to actually make use of local data, i.e. funding from the agency general funds that were used to initiate a suicide prevention program. And these are some of the elements of that prevention program. Specifically, they trained hundreds of gatekeepers who were out in the community. They were in a variety of capacities, but they were individuals who were trained on what to look for people with suicide ideation, and then how to direct them to appropriate resources. Importantly, they raised awareness in our community, and key partnerships were established. A couple of impacts, as I mentioned, hundreds of gatekeepers, a walk called Out of the Darkness. It's interesting when you look at suicide that it's not necessarily something that we as a culture feel real comfortable talking about. Again, worked with a variety of partners and really trying to get the word out. And again, facilitated conversations in trying to increase local resources and capacity. In 2013, that funding went away, and as a result, what we have is sort of a grassroots effort right now at trying to keep the word out and really trying to, again, make people aware of it. But the reality is, I think we're all aware of the fact that a lot of these issues, although they may be out there, really don't seem to resonate with us until they hit us personally. I will speak for myself. Personally, a couple of years ago, my wife had an employee, a young 30-year-old gentleman, who took his life at work. He had 2 small children. My wife, likewise, lost her aunt 2 years ago to suicide. I have a dear friend from medical school, lives in Palo Alto. Okay, Palo Alto was experiencing a cluster of youth suicides. Cluster is sort of epi-speak, if you will, for meaning a sort of an increased number of individuals in a geographic location and at a time. So we were seeing this cluster, and the reality is that these clusters are occurring nationwide. But again, I would point out that it's not just with youth. We're really seeing this issue at all age groups. So looking at national data from the CDC, we see a general trend. Again, males on the top, women on the bottom, but again, we can see that trend upwards. And essentially from 1999 to present, we're seeing an increased number of suicides, incidence rates. For women, again, although we will talk extensively today about youth suicide, the reality is you can see that this is affecting all age groups and especially middle-aged individuals. And a couple of years ago, a couple of researchers, Case and Dunbar, came up with the phrase diseases of despair, diseases of despair. And what they identified was that disproportionately we are seeing white people, white individuals with low SES are falling prey to substance usage, alcohol usage, the toxicity associated with that usage, and suicide. And so we are seeing more and more of this in our nation and locally as well. Again, for males. And then it shouldn't be any surprise, again, if you look internationally, individuals who decide to commit suicide will make use of that instrument, if you will, that is most prevalent. So for example, for a number of years in Thailand, women were committing suicide at epidemic proportions, and they were using a chemical, basically a house cleaner, to commit suicide. What the government did was they eventually banned that substance, and rates of suicide went down. So what you're seeing here is that disproportionately, these are, again, the instruments, if you will, of suicide. Males will tend to use guns more so than women who will use poisoning. But of concern and of note is that suffocation, i.e. hanging, is now seeing an increased rate. And it's hitting all populations demographically. This slide just illustrates the fact that although we may at some level, because we're in Spokane, function or really focus on the city of Spokane, the reality is that rural populations are being affected by it very significantly. And the upper line again represents rural populations. This is again looking at CDC data, and you can see 10 leading causes of death, and green represents suicide. So again, at the 10 to 14 year age group, third leading cause, but as we go up, again in the 15 to 34, it's the second leading cause of death. And this slide again focuses on the fact that, again, the different mechanisms, firearms, suffocation, poisoning. What we see here in Spokane and Washington State is again consistent with national norms or national statistics, i.e. trends on the upward since about 1999. And again, hitting all demographics, hitting all age groups. And again, as I alluded to before, trends in all age groups up, not necessarily down. Again, local data, firearms, suffocation, poisoning as the leading causes. And specific for youth, I'm not going to go into details in the handout that was presented to you. Again, it's a great example of how the data center and communications work together to provide that in a very short order. But again, there's a lot of data in there that I want you to look at. But as we see here, these are again young people in the 8th, 10th, and 12th grades who are giving idea to suicide, what we call suicidal ideation. Not only like thinking about it, but more concerning, making plans to actually act out on it. And then relative risk of, again, looking at different risk factors. We see depression as a major cause, as well as a variety of other factors. And I just want to make one mention. This is another one of those epi moments, if you will. Relative risk. It's a epi term that we'll commonly use. What it generally implies is that, again, if you look at this sort of busy slide, if you have a relative risk of 1, it essentially says that your risk as compared to another population, i.e. a control population, is essentially equal. If you have a relative risk greater than 1, then you're at increased risk. If you have a relative risk of less than 1, again, it's a lower risk. So if I go back to this slide, what I can see is that young people who are depressed have a significantly increased likelihood of having suicidal ideation and maybe acting out upon it as compared to their counterparts, their young people who don't. So again, relative risk is a EPI term that you will commonly see mentioned in this report, but also again going forward. And so what I'd like to leave you with is that today we'll be hearing a lot about suicide locally. We'll be hearing about suicide in young people. We're hearing about suicide across all demographics and across our population. What I want to put forth is the fact that this is indeed an epidemic of national and local import. And importantly, we need to look as a community of what we do, how we can mobilize to really affect a change. Because this is not something that, again, is purely and simply a function of 1 or 2 elements, 1 or 2 things that we can isolate. Rather, it is multifactorial. And so really looking at those areas where we can have impact and how do we mobilize as a community to really have effect on this crisis. Okay.
Dr. Lutz, quick question.
Yes.
You used an acronym, SES.
I'm sorry, socioeconomic status.
Thank you.
Thank you for holding me true to that. I use a lot of acronyms. Yes, ma'am.
So what are all the demographics that you've looked at? You looked at socioeconomic, you looked at zip codes, race, gender, you looked at gender, you looked at age, what else?
So again, I would fall back on asking the data center the different age group, I should say the different demographics, but the typical demographics, again, if you're talking about for our community, again, it's age, educational status. I don't know to the degree that it went into zip code. I can find out for you about that. Okay. But again, it's primarily age, SES, race, ethnicity.
Okay, and the reason I ask about zip codes, we know that we have the poorest. One of the zip codes in Spokane is the poorest in the state. Right. So it'd be interesting to see if there's any correlation.
Agreed. And again, that's a great question for the data center to really kind of tease out. I'm not sure of that.
Any other questions for Dr. Lutz at this time? Thank you.
We'll now have the legislative update from Linda Graham.
Well, this is going to be pretty short because there's not a whole lot to tell. Hopefully you know that we have a handshake agreement amongst the leadership of the legislature for a budget, but we have no details as of yet. What we're hearing is that they are working internally to try and get everybody on board in the House and Senate to the deal that they came up with before releasing any details to the public. So we don't know yet about the Foundational Public Health Services funding or any other public health funding that may or may not be in there. Hopefully they will release some things either later today or tomorrow. So hopefully we will actually avoid the shutdown of the state. I will tell you on the Foundational Public Health Services piece, the House passed it again in the second legislative session, which is a good sign in terms of wanting to sort of reinforce their continued support for the funding. But they didn't do so in the third session. But any of the bills they were taking action on as these sort of signs of support from either the House or the Senate, there wasn't any further action in the third session either. So it was good that we had some action on it in the second session, but still don't really know what's going to happen there. So any questions?
Seeing no questions, thank you, Linda.
Good. I'm glad there's no questions because I don't know a whole lot.
Good afternoon. I have a few items to go over. First, just briefly, how excited we are and thrilled that we have Dr. Lutz on board. The transition is going very, very well. Internally, Bob has been around to visit with most of the staff in the agency and has a plan to set many meetings up in the community and begin to integrate there. So I'm just thrilled and thankful you're on board, Bob. In your packet is just a chronology of where we are with the PFAS issue, the contaminated water. from Fairchild and Airway Heights. That is an issue that we continue to provide information to the public on in terms of risk. We have to recognize that it is not a regulated substance, and so there's sort of this challenge there. And we as well are not sampling it. That's being done by the Air Force, and so we don't necessarily have all of the data. But that is being watched closely by the Air Force and those folks in Airway Heights. We had an opportunity on June 14th to have the State Board of Health meeting here in Spokane at Gonzaga University. They did a lot of what the state normally does, which is related to procedurally around rules. They looked at rules on individuals with disabilities, issues on environmental health and safety, newborn screening, and rabies and how to reduce likelihood of transmission of rabies to humans. They also spent some time looking at the national immunization guidelines as it relates to WAC 246-100-040, so that we are making sure that as a state we are staying in alignment with the ACIP recommendations. And they had a presentation on mobile immunization clinics, which is exploring innovation in looking at how we link schools, health, and public health in a continuum of care to assure that we can reduce disease as greatly as possible. So it was terrific to have them here in town. We also had an opportunity to provide an overview of Spokane Regional Health District and where we have been and where we are going. I also wanted to acknowledge that we have received a donation from an individual for the Nurse Family Partnership Program in the amount of $10,000. The person wishes to remain anonymous, but a person who recognizes the value of that program to women and children in this community. And we are deeply appreciative. In terms of information that Mike Riley would normally share if he had much on his plate, we just need to let you know that the audit has been completed and we will have an exit interview date set, but all went very well with the audit. The Profix software, which he has been working diligently to get in place, will be displayed with the Budget and Finance Committee in their meeting on the 12th. And so it'll be exciting for the board to begin to understand how well we will be able to track and report out on financing. And then thirdly, I know you were asking about a quorum for the meeting coming up in July. We are hoping that we do have the quorum because we will be bringing the fee schedule to you. It will be going to the Budget and Finance Committee on the 12th, but we want to have a quorum to be able to vote on that if possible. And then finally, Councilmember Munch had asked about where we were with the after action review in a phone call the other day, and it is nearing completion. We're looking at what has gone on with the exclusions and the mumps work. And after that is wrapped up, and probably by the end of July, we will then be setting a meeting with the superintendents to then have a dialogue about what can be done differently or better in next outbreaks. So those are my updates. Any questions?
Questions for Torney?
Thank you very much.
Thank you. For the record, Councilman Beggs joined us at 12:50. So thank you very much. Are you available on the 27th?
Yes, I got emailed that.
Okay, excellent. Thank you. So next up we have our consent agenda consisting of the meeting minutes from the May 2017 meeting and the vouchers for May 2017. Do I have a motion on the consent agenda at this time?
Move to approve. Second.
Moved and seconded. Any discussion? Seeing none, all in favor?
Aye.
Any opposed? The consent agenda is approved. Item number 7, action items. We have a resolution, 1706, authorizing the Spokane Regional Health District Administrator to enter into mutual aid agreements with other health jurisdictions for health officer, substitute health officer, et cetera, et cetera. Tony, do you want to take that?
Thank you. One of the things that we try to put in place between health officers are agreements so that in any given health officer's absence, we have somebody who is covering the responsibilities. It was demonstrated in the long term that we did not have a health officer here with Sam covering, Dr. Artsis covering for us. I know that Dr. Lutz has talked with Dr. Artsis about having an agreement to be able to cover for one another. That is simply mutually agreeing to be there to cover for another individual. At our Wasolfo meeting, I was asked by other health officers in our region to perhaps get on a similar arrangement where they can have multiples, different options to select from in the event that any one of them is out of town or unavailable for their county. So what we are seeking here is authorization from the board so that I can set up those MOUs with the various counties that want to do so.
Questions? Lori?
Is there a financial component?
There is not. It's mutual agreement to share for one another.
Any other questions for Torney? Thank you. So has legal reviewed this?
Yes.
And all consistent? We're all good to go on that? So do I have a motion on Resolution 1706 as presented?
I'll second it.
Moved and seconded. Discussion. Do we have any discussion on this resolution? Seeing none, all in favor of Resolution 1706 as presented?
Aye.
Any opposed? None. Resolution 1706 is passed. Next are our reports. We have a report regarding suicide awareness, and then we will have a report regarding peers practicing prevention. For suicide awareness, Dr. Lutz, could you give us the introductions on this report and who will be our speakers today?
Yes. I've never met Stacey. Is Stacey in the audience? Seeing none. So when I talked with her earlier, Stacey is one of the key individuals down at Frontier Behavioral Health. And so when we were in conversation, she may be coming a little bit later. David Crump, who represents the school district, will also be here. And we talked a little bit beforehand. He was going to go back to his office and return.
So neither of our speakers are here at this time.
Correct. Neither are here.
So
I'm happy to.
No, we don't need a song and dance. Let us move on to peers practicing prevention at this
Great
time.
idea.
Kyle, could you come on up and give us a presentation on that? Thank you.
You're going to have to speak a long time, Kyle.
I guess so. All right. Thank you for the opportunity to come before you today. Again, my name is Kyle Lundland. I'm the Division Director for the Division of Health Promotion. I want to talk to you today about peers practicing prevention. It's a project of the Youth Marijuana Prevention and Education Program, Health Communities, and the Division of Health Promotion here at Spokane Regional Health District. Spokane Regional Health District, just to give you a quick background of what this project's about before we get into the actual presentation, which I want to get to really quickly, because that's the cool stuff. All right, but Spokane Regional Health District is the regional lead for this project, which is funded out of the Department of Health, Health's Youth Marijuana Prevention Program. And these funding coming from this is from tax revenue from marijuana sales in accordance with Initiative 502. Our funded work in the program started in April of 2015. Youth marijuana prevention in the state where marijuana use is legal for those who are 21 and older is new. Current evidence-based practices have not been tested in this legal landscape. Developing youth as leaders is a best practice in other substance use prevention efforts like tobacco and alcohol. As part of the overall strategy to decrease youth marijuana use, Spokane Regional Health District developed a grant called Peers Practicing Prevention and awarded 2 groups of youth funds to work on the project related to youth marijuana prevention. Upon completion of this project, youth are required to present their projects to key leaders in Spokane. The Spokane Regional Health District Board of Health was chosen for its cross-jurisdiction representation. So, without further ado, let's go ahead and have WSU 4-H teens as teachers come on up and give us your presentation. After that will be YouthBuild Spokane.
I'm not the teen. I'm Gary Varela. I am the Washington State University Extension Specialist assigned to 4-H Youth Development in Spokane County. Our teens, the cool part, are down here along with our Healthy Living Coordinator. One of the 4-H mission mandates nationally is healthy living. Spokane is very successful in securing competitive grants to develop youth-targeted healthy living projects in nutrition and, in this case, substance abuse. Through those projects, we're fortunate enough to be able to hire a very talented person, our Healthy Living Coordinator for 4-H in Spokane County, Jennifer. I'll let Jennifer Fees introduce our team.
We had 13 times did we see people using these products out in public, 10 visual signs of deterrence that we were able to see, and 9 billboards and signs advertising for these products. All right, so some of the things that we learned, it was just how shockingly common that it was that these adults and other teens were vaping, and especially around where teens and youth gather, and this normalizes it. And so does these ads, like this Stoner Dad ad that we got off the spokesman. It just shows how normalizing this is becoming, and also just where these shops are located, and they tend to be near places like pizza places and ice cream shops. And so as we studied the data, we found also that the evidence of use was really common to where adults and kids hung out. And it wasn't necessarily where they purchased their product. It's become a leisure activity, actually. And and then again, like all this public use and advertising just promotes this acceptance, and that kids now think that it's okay to become users of this product.
And what we plan to do with the information that we collected with the survey is we want to implement it into our Health Rocks program, which is a national 4-H program centered on tobacco and other substance prevention. And as well as that, we plan to integrate it with our 2017 Youth Summit on Healthy Living. That will be taking place later this July, and we have some really good stuff to share.
So our call to action would be developing an educational program that we could teach to elementary, middle school age youth.
We also want to reconsider policies related to where vaping is allowed. Like, should we allow vaping to take place in playgrounds?
And we may also want to reconsider the zoning laws that surround vaping and marijuana businesses, because as we mentioned, we noticed that they are very shockingly close to places where people our age and younger tend to hang out. May we answer any questions at this time?
Questions for the group? Green.
Yeah, so, and you might have said this and I might have missed it, but in terms of how you define neighborhoods, the city defines them. We have 29, I think, specific name. Is that how, or did you have another definition of a neighborhood, or we're using the official city, like the Manitou neighborhood, the Rockwood, and those things?
When we said neighborhoods, we were more using just the kind of colloquial version of neighborhoods.
Okay.
So like, let's say South Hill is, everybody knows what South Hill is. I'm not sure that we know necessarily the legal definition of that.
So, all great work that you've done, but if you do it again, that will really help the cities for the data, because it's hard to, when you're talking about numbers of things like that and where and things like that, it'll make it easier for us to address policy.
Yeah, we have the actual physical locations of every single survey that we did take, and we have that information if you'd like it as well.
Mike.
Where will we get that information at?
We have the sheets, don't we? Yes.
Perfect, thank you.
Josh.
Do you have any specific recommendations as far as zoning changes surrounding marijuana retail shops?
There was an article that I believe talking about former representative, Aher, that had regarding specifically, I believe, 1,000 feet from churches and other, just churches. And I would consider myself a proponent of that.
Okay. All right.
Breen?
We should probably already know the answer to this, but I'm still going to ask. So one of the things I think it's been most disturbing to me is the advertising. And do you have any knowledge of yet what authority local jurisdictions have to limit advertising for marijuana and vaping shops as opposed to it being a state or a federal issue? I'm just wondering if you've looked into that yet.
We have not looked into the specific laws, however, driving through division, you can tell that is clearly an issue.
But we know it's an issue, yeah. So, yeah. So, okay, thanks.
Dr. Lutz.
Great report. I was curious, being teenagers and being exposed to this marketing, conversations between you and your peers, what's your take home from the marketing?
It's pretty influential. I just went to a friend's birthday party, and about half of them were high on something, and they're all under 18, so they're obviously pretty influenced by the advertising and the marketing, so I'd say it's a pretty big deal.
Lori.
And a follow-up to that, where do you think people are actually getting it? They can't buy legally, so are they getting adults to buy for them, or do you have a sense of that?
I have honestly no idea.
Okay.
Sorry. I have known of many kids who have gotten marijuana products from adults and people older than 21. I've seen that myself. I don't have any actual data on that, but I have certainly heard quite a few friends doing that.
Mike?
Do you think this is an increase from legalization? I know you guys are fairly young, so you probably didn't see a lot of it before it was legal, but is it a greater risk for you guys now to run across at parties before it was legal or after? Do you have any idea?
Personally, I think that the access to marijuana products has increased, and I would say quite dramatically since the legalization to people my age.
Chuck.
In your progression as you moved through this, did you find out within the high school levels of people you were talking to, because of the increase of marijuana, the possibility of marijuana and kids using it, was there different types of behavioral problems that you brought up that were happening in our high schools? Or was that taken into consideration? Was not.
But another way to phrase that question might be, are you seeing a change in the behavior of the kids in the schools because of, at least Caleb in your case, an increase in what you perceive as the prevalence of use?
Yes. In my high school, I've noticed many of my fellow peers going to class high, and I've noticed them not performing as well as they should because of that. And I can't necessarily give the right perspective as pre-legalization because I was, basically entering high school when that occurred. But I know that it's certainly a problem. Everything.
Well, yeah, specifically at LC, I know especially at lunchtime, people will go into the freeway and they will get high and then they will come to class, and especially that fourth period coming back, everyone's a little all over the place, and I think that's definitely a really big problem.
Bob.
Just another question for you. What's the perception among youth of kids who use? Again, going back to my generation, there was a stoner group, and they were pretty much marginalized, and everybody knew they were stoners. And I'm kind of curious, are they still looked upon as stoners, or is it cool to use, or what's the kind of vibe right now in schools around usage?
That's actually a great question, because I have seen in my school, at least, I don't know if that's true across the whole county, I have seen that the people who do use marijuana are not necessarily seen that different as opposed to people who do not. There is at least some level of a divide there, but the average kid who, does okay in classes seems to have his grips on things, but, maybe uses marijuana every once in a while. It's not a big deal.
And just to follow up therefore, I mean, if that's your observation, then that again speaks to the fact that it's being normalized.
Yes.
So the behavior is being normalized, which is ever so problematic, because then if it's a normalized behavior, then it's perfectly acceptable, and all the issues that come with that become evident. Okay, thank you.
Any other questions?
Since you're giving us your limited snapshot in marijuana, I'm just wondering, alcohol, is that used by lots of kids as well in your school?
It is absolutely, yeah. It wasn't part of our project, unfortunately.
No,
yeah. Where I live, very, very prevalent.
Okay.
Lori?
Did you do a breakdown for gender? Is it more prevalent with males or females, or was that part of the study?
Not in our project.
What's your opinion as kids at school?
Personally,
Separate vaping and marijuana.
I think definitely for vape specifically, I think that in my experience, males are more likely to be open about it and do it in public, but I found that females use it just as much, but they use it in the privacy of their own home.
I agree to that.
All right, at this time, I think we're going to move on to our next presentation, which is, yes, thank you all. Thank you very much. My apologies. Our Stop 21 group.
We are YouthBuild Spokane, and we took part in the Peers Practicing Prevention with Spokane Regional Health District. Our group consists of young adults that have various experiences with marijuana. At the youth center, we showed videos discussing our members' personal stories and went over brochures. Our ambition is to contribute to the prevention and minimize marijuana use for adolescents and adults younger than 21. Our logo is to stop under 21 use, which is right there. During our presentation, we introduced ourselves and presented our personal stories, and then we gave our audience brochures and gave them a quiz about the risk in marijuana use. After the video and quiz, we asked them if they had any questions, either about our stories or presentation. Following the video, quiz, and questions, we asked them to fill out an evaluation based on our presentation. At the end, we gave them t-shirts. Our audience was a presentation in front of 11 and 12-year-olds, and during our presentation, the audience paid a lot of attention and asked questions and enjoyed our company.
We also did a brief sampling of 3 zip codes in our area where we counted marijuana dispensaries and billboard advertisements. In the 99202 zip code area, there are 3 dispensaries and 1 medical dispensary. Also 11 billboard advertisements with 6 schools, not including a GED program for 16 to 24-year-olds and YouthBuild. You can also see there's more dispensaries in the 99202 area compared to the other two zip codes. Here's a Google Earth photo of the 99204 zip code area with the location of the K through 12 schools. The Lewis and Clark High School, Mary Cliff High School, and the Roosevelt Elementary. A Google Earth photo with 99223 area with the locations of schools and 1 medical dispensary. The medical dispensary, All Saints Catholic School, Lincoln Heights Elementary, Adams Elementary, Ferris High School, Warren Prairie Elementary, and Moulin Road Elementary.
Here is the 99202 area with the markings of the dispensaries and marijuana ads. And An overall photo of the 3 zip codes together. Advertisements are thrown in our youth's face, pretty much saying that it is okay to use marijuana, making it more normal in the community, making it seem like it's not a big deal anymore, but it really is a big deal. Marijuana is affecting our youth in many negative ways. It's almost impossible to avoid, which makes it very hard for youth to quit using. During our presentation to youth, we tried to make them understand that using marijuana is not the norm. We think that it would be helpful to be able to limit the amount of ads done in the high-risk areas. Some of the other risks include driving under the influence, higher risks of criminal activity, risking their education, health risks, and also high risks of other drug use. Thank you.
Thank you.
At this time, I'd ask for your questions and if you guys would like to see the video as well that we made.
So at this time, what I'd kind of like to do is we'll take questions for the YouthBuild team, but I'd like to hold off on the video until after we get Dr. Crump and Stacey's presentation done. So can you guys hang out? Because we would like to see that, but we kind of need to shuffle those for people through. So do we have questions for the YouthBuild team? Dr. Lutz.
So again, your audience was a younger population?
Right.
Yeah, our audience were usually 10 to 12, but there was also other presence of peers in the room as well.
Okay.
So we were looking at the younger generation that's coming up.
Right. So the 2 questions I would have for you, therefore, would be, 1, did any of those younger children admit to and or say they were exposed to, their parents, their older peers, older sibs were using it? And then 2, your role as older students who can be looked upon as role models, do you get a sense of that in any way?
I had the sense of the role model. They really looked up to us and actually listened to what we were saying because we have the experience.
It was really nice.
And then there was also the kids that were coming out telling us, oh, my dad does this, my mom does this. The kids actually, they see the ads out there. They look at them too, and they impact them and their choices and marijuana use. So that's a big thing that we want to get across to you guys.
Any other questions? So we will bring you back up because we're interested in seeing the video, but at this time, I'd like to ask Stacey Cornwell to come on up. Bob, do you want to do the introduction on this, or should we just start? So, Ms. Cornwell is the Director of Crisis Response Services for Frontier Behavioral Health, and we've asked her to come down and give some information on suicide awareness.
Hello, everyone. Thank you for having me. Just a little bit of background. I've been...
Stacey, before you begin, as I look here, I see you are MA, LM, HC, DM, HP, CM, HS, GM, HS, and Director of Crisis Response. Is that telling me you're an unbelievable expert in the field you're going to speak to today?
You know, I do have a lot of experience. I think maybe after I speak, you can determine if I'm an expert or not. Yes, I am a licensed mental health counselor. I am a geriatric mental health specialist. I'm a child mental health specialist. The DMHP, for those of you who aren't familiar with that credential, is a designated mental health professional. And what that means is that me and my team are designated by the county to perform the Involuntary Treatment Act assessments. So individuals who are suffering from a mental disorder that are presenting with suicide risk or risk of harming other people or are not able to take care of their health and safety needs, and they don't want voluntary services or they don't know that they need it, then my team comes in, does the evaluation, and can impose that involuntary psychiatric treatment. So that's what that is. Did I miss any of the letters?
I don't think so.
Okay.
I wouldn't know the difference.
And I know that I only have a few minutes, so I'm hoping that you guys will have questions to make sure that I am able to answer what you're hoping to hear about. But I will let you know that I have been in this service area for about 18 years. I work very collaboratively with many community partners, including our schools, jails, law enforcement. We put on a 40-hour class, a crisis intervention team class, to help our law enforcement, and actually fire is attending, DOC is attending, jail staff, STA. I mean, it's a huge group of people on the risks of suicide, how to identify it, how to communicate, other mental disorders. A lot of information actually is being thrown into this 40-hour class. Specifically, my primary role is I do run the 24/7 crisis hotline, which is also called First Call for Help. Some of you might be familiar with that. That's a volunteer hotline where people call in and can ask for assistance with themselves or their loved one because they're at risk of suicide or homicide, or they're not taking care of themselves. And then those volunteers will route it to a mental health professional if it rises above the scope of what the volunteer needs, or if they need mobile outreach, some sort of face-to-face. So we are a 24/7 resource. Every single caller that we have is probably expressing suicide. I mean, that is our business. And we do have a lot of people that have thoughts of harm other people as well, and we have a lot of people who aren't taking care of themselves, but suicide is our number one type of call, and we get a lot of them. In fact, we probably, between my two crisis hotlines, and I'm not the only crisis team, and we also have, through Frontier Behavioral Health, some other crisis response type teams, and throughout the community, there's a lot of people that are making this effort, to try and work with individuals that are at risk, that are homeless and suicidal, or that are veterans and suicidal. But usually by the time they get to my team, all these other resources have been exhausted. There are no other options, and the person isn't willing, or they don't know that they need that help. And so my team comes in, does the assessment for the involuntary care. The things that we look for, and again, I'm just going to go on until you guys tell me stop, okay? The things that we're looking for when we're assessing a risk for suicide is if there's been noticeable change. And it's not so much that the person is moody, because we know that a lot of our teenagers are moody, no offense, but you are. We know that our younger kids also are very moody. I mean, all of us are. And so it's not just that there's mood change, or that all of a sudden, people aren't sleeping, or they're eating more, or whatever, they had a bad day. It really is noticeable and observable change in mood, in behavior, in performance. So at school or at work, if we're talking about adults, we look at noticeable change in if they're feeling hopeless, if they're not interested in things anymore that they used to be interested in, and if they're already expressing thoughts of suicide. Those are the things that we're paying attention to. And then in addition to that, we're also looking at some high risk factors that we know based on our experience. So for example, we know that our law enforcement, veteran, military population is very high risk. We know that our Native American 18 to 24-year-olds is a very high-risk population. We have our middle-aged man who's divorced, who's lost his job, who's drinking alcohol, very high risk. So we have identified characteristics that aren't necessarily a profile, but there certainly are red flags for us when we're interviewing someone. An elderly man that's 65 and above is one of our highest risk individuals. An elderly man that's a caregiver for his wife is probably our highest risk person that we're seeing. So we keep that information kind of in the back of our heads too as we're doing these assessments with individuals. And we're really trying to figure out what is it that's going on with them, and what is it that we have to offer in terms of resources or just listening. What we have found is some of the best interventions when someone has suicidal thoughts is that they just want to be heard, and they want someone to listen and not to be judgmental, to be very respectful, to protect the dignity and autonomy to the extent possible. And so that's what we try and accomplish with each of our interactions. And don't know what else you want me to talk about, or maybe I can open it up for questions.
Yeah, why don't we move to questions? Do we have questions from folks? Any interest? Mike?
So when you talk about involuntary commitment, what does that look like? Do you have a board that has to be convinced, or is it just down to one person with a background that is able to make that decision?
So it does start with designated mental health professional, and there's special training that they receive to become designated, and the county determines that they meet that designation requirement. And so, for example, me, I would come out and I would do an assessment of the individual, but I'd also interview other people that might have information that would add to the allegations or maybe disprove the allegations, or just add additional information. And then if I do make that decision to detain the individual, the authority that we have is 72 hours, not including weekends and holidays. And at that point, that person is held, usually in an emergency room, because we have a shortage of psychiatric beds and we aren't able to move people directly. And so we hold them under this involuntary process, and then it moves into a civil court process. We file a petition to Superior Court. Within that 72 hours, court convenes and meets to determine whether or not that individual needs to be committed for an additional 14 days, or if they can be released voluntarily, or maybe at that point, because there has been a couple of days the person has been on medications, maybe they're stabilized enough where they're recognizing that, you know what, I do need help, and so they agree to stay voluntary. So there's certain outcomes that might occur at that court hearing.
One last, and we'll move to Chuck.
Thank you. And then I've heard from several people in several places that housing for suicide prevention type services is just way taxed. Is it, I mean, you alluded to you're keeping them in emergency rooms, or are we doing that with lots of even involuntary or voluntary turn-ins, so to speak, or what are we doing? Are we turning them away? How does that work?
I'm not sure I quite understood your question, but I think what you're asking is, yes, we do have a shortage of inpatient psychiatric beds, and we have a group of involuntary people that are looking for those beds, but we also have people who are trying to access services on a voluntary basis, and they run into the same issue, is they sometimes are sitting in an ER just waiting for the next bed to become open. We actually look for beds all across our state. We send people across the state for inpatient psychiatric care, and then they come back when they're stabilized. So is that what you had asked?
Yeah,
okay. And then I should clarify, the involuntary treatment laws only cover 13 and above. So anything below that, my team does not have authority over. Okay.
Chuck?
If I'm contemplating suicide, how do I contact you? Or how do you find out about me? What's that process?
Okay, there's actually a few. If you know where to call, that's what we would ask, is that you call 838-4428. That's our 24/7.
How do I know that? Why would I contact you if I'm contemplating suicide?
Because hopefully you've attended this meeting and you've heard this number. We do a lot of community outreach. I mean, I probably go out 5-6 times a week talking with individuals. We also have a gatekeeper model where we train, bankers, postmen, people who are non-professionals in the mental health world, but have contact with individuals. So they notice that you're no longer coming into the bank, and that's really unusual because you come in every Tuesday. So then they might call us. And so we do a lot of community education and letting them know what to do when you're concerned, who to contact, and kind of what that process looks like.
My second question may be answered later on. But say a suicide takes place in one of our large high schools. Mm-hmm. Do you provide counseling for that staff and for those kids, or is there a different approach that the school district takes?
Both. We have been called in to assist in certain situations, and I know that Dave Crump will speak a little bit about their crisis team that they have embedded in their schools that will respond to those as well.
Okay.
Other questions for Dr. Lutz?
Yes, Stacey, you mentioned that you don't have responsibility for children under the age of 13. Where does that, do they fall through?
It's, the parents have ability to consent. So the age of consent for mental health is 13 and above. So a 13-year-old could present themselves to the hospital and sign themselves in for psychiatric treatment. If you're under that age, the parent has to do that. And regardless of whether the kid wants to or not, the parent can do that.
And then one of the things I'm very sensitive to is, and you sort of alluded to this with, sort of follow up on Mike's question, I mean, there is a lack of resources, there's a lack of beds.
Mm-hmm.
And my personal experience with friends and neighbors is that, especially for adolescents,
Mm-hmm.
There is a marked dearth of resources for that age group.
Mm-hmm.
And, when we look at that at a community level, and if we're identifying this as a crisis, where do you see opportunities for us to kind of address that?
Those are great questions. Spokane is very rich in community resources, especially with the youth. But when it comes to inpatient psychiatric beds, they are limited. And a lot of people do bring people to the hospital because they think their person needs inpatient care. And fortunately, our hospitals are very good at starting the treatment, even if they're sitting in the ER, waiting for that bed. And sometimes what happens if a bed never opens, that person gets better enough, can be referred to an outpatient treatment program, and so they never make it into the hospital, and it frees it up then for someone else. But it's not so much that we don't have the resource and so there's no access to anything. There really is a lot of effort with our community partners to provide the level of care that people need. It's just not necessarily sometimes in the ideal place, sitting in an ER, getting your psychiatric treatment. I know that they have this new facility that is opening up, Providence and Fairfax partnership. I don't know if that is going to be youth or adult at this point, but that's a 100-bed facility that will bring in some additional resources. I just don't know the details beyond that.
Mike?
I've been told that there's basically a 12-minute window when somebody's at risk contemplating suicide, and so if you can help them through that crisis moment, then they're generally, they're not okay and fixed, but that's the crisis moment. So are you doing a lot of that type of education to the gatekeepers, so to speak, since there is a so-called housing crisis, to delay, these people? Is that kind of your focus since there is a shortage, or what is your guys' attack method for that stuff?
I haven't heard the 12-minute window. If people are having the thoughts now, or if they're actively engaged in making the attempts, well, let me speak to that. If they're actively engaged, it's a 911 call. It's not my team. When you call us, you get someone like me, and I'm not about to wrestle a gun away from you or, pills or anything like that. That really is an emergency call. But if it's more they're thinking about it, they're pretty intent, but if they're willing to talk with us, we have all the time in the world. We spend hours with individuals, sometimes 4 to 6 plus hours working through each of these referrals that we get. And it really is about listening. That's the best advice I give to anyone, is if you can just listen, and so that person feels heard, understood, then hopefully they'll come around to be willing to accept help. It's when they feel dismissed or maybe judged, then they start to shut down because you're maybe responding like, oh my gosh, why would you do that? That's, if there's guilt and shame that's attached to it, then that might steer them in a different direction. But I will say, even though they feel heard and understood and agree to, yeah, you're right, this is not what I want to do, I'm willing to accept help. What I train people is the minute they leave your site, you've lost complete control over what they're going to do. And you might have the best plan in place and you were the best listener, but you don't know that the minute they walked out, they went home, they got beat up by their person or their father, or they drove past a liquor store or a marijuana sign and stopped by and used again, and then all of a sudden they're back in crisis. Their solid safety plan has been derailed, and then they do something. So we do the best that we can with the individual that's in front of us. We assess to see, even though they're agreeing to certain things, do we really feel that they're going to follow through? And when they don't, then that's when we look at imposing the involuntary treatment laws.
Brian?
Yeah, I just wondered what top 3 things you think should be happening in the community that would reduce the risk of suicide in our community? If you had resources and magic wands, what are the 3 things?
Top 3. That's a really good question. You know what? No one has ever asked me that before. The biggest, I mean, obviously prevention is what is our best strategy. And so the more aware that we can help people become, what to do, who to ask, how to respond, I think that is a huge saver. There's still quite a level of stigma with mental health, especially depression, especially if you're a male with depression, especially if you're a veteran male with depression, so there's still a lot of that happens, and we're making a lot of efforts in changing that as well. We use a lot of peer support specialists in our mental health system, and so these are individuals with lived experiences of mental health or drug and alcohol that will also partner with us and go out into the community and talk about their own experiences and kind of align to say, hey, you know what, it's okay. I'm not weak, I'm not this or that. I am a person and I'm working and I want to help you. And so I would say that would be the second one, is trying to reduce that stigma. For youth, I would say the biggest thing is getting parents to talk to their kids about it. It doesn't put the idea in their head, but it's such an important topic, and it's so out there right now with our media, our social media, our schools, kids talking about it, Facebook. There's a few things that I will remember from certain speakers, and this one guy said he lost his boy, he was 12 years old, to suicide. And he said, I talk to my kids about sex and drugs, and I never talk to them about suicide. And it's true, we don't, because it's a scary concept. And so getting parents, I think, to feel comfortable with that would be my third. Thank you for that question.
Other questions? Stacey, thank you very much for your time today. We appreciate it.
All right, I brought brochures and cards and also posters. I know you said you wanted. I can stick them in the back for you too if you guys decide to take them. Thank you.
Thank you.
Thank you.
Next, we have Dr. David Crump from Spokane Public Schools. Thank you.
It's really nice to be with you. It's nice to see many of you again. So, I have the privilege to work for Spokane Public Schools. I'm the Director of Student Services, work with high school. Want to kind of just, I may be a little bit edgy today, and I do want to kind of tell you why. I've spent my morning dealing with a suicide. We had a suicide of a student from Lewis and Clark High School. And we've had a crisis team up at Lewis and Clark today, and I'm in charge of the high school crisis teams. It has not really hit the news. It's summertime, and it's really sad. So the timing is a little emotional. So if I go there, I apologize. We're talking about the S word. When I was growing up, that used to be sex. And today, Stacey did a really nice job of saying, we don't like talking about suicide. We have crazy Uncle Bob or Grandma's sister who was twice removed in our family tree. It's there, but we don't talk about it. Our veterans are dying by a lot, our elderly population. And when it comes down to youth, it's a travesty, and it really gets into a loss of hope We go into neurological development. What's the last part of the brain to develop? It's the prefrontal cortex. It goes into problem solving, executive functioning. And it's like, I got to tell you, our youth today, suicide is part of the culture, and that is a really deep statement. I need you to understand that at a deeper level than go, okay, Dave, thanks, nice. No, it's in songs, it's in movies, it's in TV miniseries, it's Facebook, social media. It's part of the conversation. You as parents or grandparents, it's not part of your conversation. There's been no scientific or clinical proof that mentioning it or bringing it up promotes it. It just does the opposite. Spokane Public Schools, with help from other community agencies like Frontier, like ESD 101, like Children's Home Society, Native Project, we have put on 7, 8 different community forums all across the city to talk about that. I can't tell you how many times I've had students after those meetings come up and say, thanks. Thanks for even talking about it, because there's nobody else. It's a subject that makes people uncomfortable. Doing that actually relieves the stress. Let me kind of tell you that one of the most challenging and difficult parts of my job is I can quote you what the national profiles are. I can tell you that. I can say, depression is the most common co-occurring substance use is the second, blah, blah, blah. I mean, I can give you that. Well, let me talk Spokane. These young children and adolescents who are dying by suicide do not fit the national profile. That really bothers me, because give me a profile, I can develop an intervention plan. We don't have kids being bullied that are committing suicide. We don't have kids that are these ciphers in this, out there. And we are having our youth that have good support, that have friends, that are engaged in activities. We had another young man last summer, just right after graduation, from another one of our high schools. He had graduated, accepted to college, killed himself. Our profile's not the national profile. And it really bothers me, and I'm glad I still feel, because I've been involved in the last 10, 15 years of every suicide that Spokane Public Schools has had. It's not a nice fact to say, but that's been my job. And in many ways a privilege, but I wouldn't like to be this person's talking to you about that. But this little family today is dealing with the loss of their child. And give me a profile so I can help intervene. The dad, told me, said, well, not me, to the principal, said, we saw no signs. So, I think you heard a testimony about earlier today about mumps, and we've not seen anything like that have any indication, but we do know that stress of being out of school or stress being different, yes, that does play a part. I mean, our adolescents and our children are dealing with all kinds. And it's like, how do we help them? We reach out, we listen, we're there for them. Spokane Public Schools has done a really nice job of training all administrators, all counselors, nurses. I mean, we've done summer institutes, talk about signs, symptoms, prevention, intervention. It's part of the mental health curriculum, Frontier Behavioral Health, ESD 101. Jill, raise your hand. They both teach mental health first aid that we've brought in to the schools, and then they offer in the community. We've done these forums. The last one, unfortunately, was at Lewis and Clark on June 6th. We had great community. It was publicized, it was televised and retelevised by 2 TV stations. People are really trying to understand. We look for blame as a society. It doesn't do any good, but we like to blame. We say, wait a second, what's the cause? I want to find a blame. And when it comes to a youth or a child, we really want to do that. We're not finding that. And those are kind of, I mean, in the last forum, there was a question about the miniseries, 13 Reasons Why. Well, I met with a family of, we lost another child from North Central this year, North Central High School. And I met with those parents, and they said, you know, my child watched that show 2 days before he killed himself. Well, I'm not here to say that caused that, but it's just another, what is a stress and an influence in these children's lives? We need to be aware of what's going on. We need to be able to talk and be willing to listen to them, to validate, to help them. We often don't talk about the protective or the resiliency factors. You know, the pro-social, just being able to talk about it, being able to listen without judgment, listen without, quote, giving the answer. There's huge steps. But, I mean, I could go on for a while, but it's difficult to lose one, and horrible. And so I'm sorry I'm a little bit emotional today, but just spending the morning with that, and it impacts adults, it impacts children. And it's a loss to society. That's the youth. But like Stacey said, that's not our only vulnerable population. And we need to be aware of that. So I'm here from the schools to kind of tell you, you know, the prevention, the classes, the reaching out, the education to the staff. We have crisis teams that go to each level, elementary, middle, and high school. They're trained intervention, and then we try to use community resources to help do that. So I'll stop rambling, and if Bob, is that kind of what you were looking? Do you have questions for me? I'd be happy to have Stacey answer them.
So Dr. Crump, actually, given your day, are you willing to take a few questions?
You bet. I'm great.
All right, so Chuck.
One question I might have is that where social media comes into this picture. And an example would be, here about 2 or 3 months ago, my wife and I had gone out to Post Falls for breakfast. And here was a family, a boy and a girl, mom and dad, and they were sitting there, and we've seen it advertised, but it actually happens. They were all texting like this, and eating, texting. And as I watched, having been an ex-high school principal, I think, where's the conversation at that table? There wasn't any. All they were doing is texting, unless they were texting each other while they were eating. And I don't know if that was a possibility or not, but I just wonder where this comes into the picture now as we talk about the possibility of suicides and not communicating in a family situation.
Let me address that pretty directly. I've seen many of our teenagers and older children text right side by side. And that's true. I mean, it's kind of, we laugh at it, but it's really true. They do. And it has caused me to change a definition, and I think we should be aware of that. When we lose a child, it's changed my definition of what a friend is. In the fact that a friend was somebody I used to go and hang out with. Hey, Torney, let's go for a bike ride. That, you know, we'd go do things. In social media world, I look at how many likes, how many friends I have. I've had children. Spokane became a very small place. We used to kind of say, let's deal with the high school. We now have to be very cognizant about saying, wait a second, they have friends from Cheney, Central Valley, Freeman, Meade, and they may have never met the person, but they're impacted by the friend. Social media, you know, taking it to a little bit further on a little bit of different science is, if you spend all your time on social media, it does impact the face-to-face interpersonal relationships, and it does. And that's one of the greatest protective factors of suicide, as well as child depression. And so there is an impact. I can't give you a statistic on that, but we've seen that. So thank you for the question.
Bob?
David, 2 questions for you. when I did some work back in the state of Pennsylvania, they actually have a required curriculum for high school students. Is there something similar in Washington State?
Yeah, it's within the health curriculum.
Okay.
I walk thin ice here because I want to say support my paycheck, but I also say that being in one class is not enough. I mean, honestly, it really isn't. It's like, this is something they're living with all the time. I mean, they talk about it, the friends. I mean, this situation, that happened yesterday is going to go out, and the kids are going to deal with it over the summer. And, we try to make it more common in more curriculum. It is a formal taught curriculum, and so they get that. But we try to make it more part of the culture, but it's not a formalized way. But I think we could do more. I mean, we have more to do.
And then the second piece is that when you were at the State Board of Health meeting a couple weeks ago, you made a statement that was very profound to both Torney and myself, and I'm paraphrasing it, but essentially it was, students want to die, they don't necessarily want to be dead.
Yes.
And I think, again, we've talked a lot about how it's something we don't talk about, but yet in that younger group, it seems to be something that is heavily talked about and at some level normalized and at some level glorified. And I think that TV show that you mentioned, I've seen articles written about it by psychologists, by pediatricians, and again, it's sort of glorified. And how do we, given that framework that we're working under, how do we try to de-glorify it?
Yeah. There's a lot of different parts to that. There's suicide contagion, which is a real thing. There's how do we deal and take care of memorials? We want to celebrate the life, but not the manner of death, But also being able to, it may be the first time a youth or a child has dealt with death. And that was going to be my closing line, is the fact that, that children, and Stacey did say about when she was talking about moodiness and the issues there, that children do want to end what they're dealing with. They want to get out of that situation or that. And the emotionality is really high. And they may want to die, but they do not have the cognitive structure to really understand that to die means you are dead. You all understand that. There's a different cognitive ability to say, it's like, and they may say, I understand that, but they want the pain to stop. But that is a permanent stop that they may not totally understand the ramifications of that, if that answered that question.
Brian.
Yeah, and first I have to leave as soon as I hear from you on this to an appointment, so I didn't want anyone to think it was because of what you said. But so I mainly want to get some feedback and just kind of also just to acknowledge, the young man that was a friend of my daughter at LC, and so since last night, it just, it hit. So, and a few years ago, my kids lost someone at LC, totally unexpected, didn't fit the profile. And I was struck as a parent going to pick up my kids from school that day of, there's no handbook for the parents of how do you talk to your kid, not about suicide, but the loss that you would not expect most kids to go through. And so I wanted to, applaud the district for having the forums and doing that and bringing that up, because I think a few years ago was like, we're not going to talk about it. And so I'd like to see more. But the other thing is, in the few years since then, reflecting on it, I think we need to provide more context and training for kids on how to handle loss. I mean, just in general. And that's one huge one when you lose a peer to suicide or a car crash or whatever, but really to start programming that in before it happens. And so I would just like to affirm getting that into the cons of the schools and not just the health class, but the Tiger class, all those different things that are out there. And I think you guys are starting to do that, but as a parent, I think we really need that, because that resiliency, we can't predict what the crisis will be, but we can get the resiliency going. So I hope you'll continue to do that.
Thank you.
Chuck.
In the olden days when high schools were maybe 12 or 1,300 in population, the administrators, teachers had more ample time to commingle with the kids, go to their activities, and be really involved. And I think as our schools became bigger and bigger and bigger, I think that has taken away that compassion that you could work with, because in many instances, we became a father, a mother, a grandfather, grandmother, almost anything. And we provided opportunities for kids to come and talk to us. So I think the size of schools, and I've never been for schools of 2,000 or 2,000 above, and yet all our high schools pretty much in the greater Spokane area are that size. Have you noticed that that is happening or not happening, or am I just imagining how comfortable it used to be years ago when I said the olden days?
Well, I am so much younger than you, I'm not sure what olden days means. No. I can tell you that students, staff, and administration have more required of them than ever before. The solution, and very seriously, the solution to this issue is not if you look at it, schools play a huge part. But if you look at it on a yearly basis, we have the kids about 3 hours and 15 to 20 minutes a day. If you go over 180 days times, and you take that percentage, 3.5 hours out of a day out of 365, what are they doing the other 21 hours? It takes the society to do that. It can't just be the schools. That's why partnering with other agencies, partnering with other groups, the parents, the religious, spiritual, the cultural aspects that come with that. We do have more requirements. I understand really, Chuck, what you're saying is schools, there was a culture change that was more supportive and relationship. Schools have brought in additional staff to try to do that. We have more counselors now. We have principal assistants and assistant principals. We talk to the teachers and we train them about relationship is our best protective tool. It has become more from a covert to now more overt, where it's taught, discussed. We're trying to make steps that way. Because one of the things in the past that schools did such a beautiful job on was they were community centers, and then they went away to be schools. And, then there were, so how do we blend those? And the district has been trying to do a really nice job, but we only have those kids, I did the statistics once, it's about 15% of their time in a year. And so that other 85%, we need help.
Okay. Well, I think the other element to that is not only the academic portion of it, but it's the activities that kids are involved in, simply because as you get larger, fewer kids can be involved in those kinds of activities. Right. So when you think the kid is there 3.5 hours, some of them were there from 7 o'clock until 10 o'clock at night. And so there has to be either, a coach or a teacher somewhere that they can model for and be able to assist and help those kids. That's kind of what I was getting at.
Nope, and we talk to all that staff and we know that. If you look at who is the most influential in your life, it may not have been a teacher, it may have been a coach, it may have been the band or the orchestra or a club. Yeah, we look at that and really try. That is a huge challenge.
Any other questions? Dr. Crum, thank you very much for your time.
Oh, pleasure to be with you.
Thank you. So let's have our YouthBuild folks come back up and we will kick off your video.
Can I make one comment to transition? I met with a student yesterday, a middle school student, and part of my job is sometimes kids get in trouble at school and I have to deal with them on the severe side. Now my little middle school friend struggles with ADHD, and he says, I don't want to take the medication. So I said, what do you do? He goes, I smoke pot every day. And he goes, it really helps. And so I said, so if you're self-medicating with marijuana, so we got into how does a middle
are local resources to help you avoid or quit using marijuana. My exposure towards marijuana is knowing my family members use it, especially since I see one of my family members stealing and lying and unemployed. I'm not sure if marijuana is the cause to their actions, but it's definitely a start, especially since they have it at all hours of the day. I believe this family member has been using for over 10 years and has been unemployed all his life. Overall, I am proud of my choice on not using marijuana because I believe it has been a benefit towards my life.
Do you know any short-term health effects of using marijuana, like short-term memory problems, paranoia, psychosis, panic, hallucinations, lowered reaction time, and problems with coordination?
You can make the wisest decisions by researching, talking to a doctor, and making the decisions for yourself.
Being a teenager, you just want to fit in and be cool. This is how I started smoking weed when I was around 14 or 15. But I only ended up smoking for a year or so because in the long run, I did not like how weed made me feel when I was high. When I was a freshman in high school, I got expelled because I was smoking on school property. After I was expelled, the school made me attend drug rehab and drug and alcohol classes in order to come back to school. Getting expelled from school caused a lot of frustration because I then got behind in school and it led to me dropping out in junior year. If I know now what I didn't know back then about the consequences and the long-term effects that weed has on your body, I probably would have waited to smoke. Now, being a parent, I will make sure my son knows about all of the side effects of weed. I want my son to be able to go to college. I also want him to be able to apply for a job that he wants and not just a job that he knows he can get because they don't UA.
How about long-term effects? You are at risk at impaired thinking and ability to learn, developing an addiction. There are increased risks of heart attack and stroke. Memory and reaction time and coordination problems can become permanent. You can experience decline in IQ, and it can lead to other illegal drug use.
By being clean, you can improve your health, school, and career outlook. My dad used marijuana around me and my older brother as we were growing up, and we saw him use it and thought it was okay to use it as well, not even knowing what it was about. I really didn't get into using marijuana until I was in middle school, around 7th or 8th grade. A couple of my friends knew I was using and I stole it from my dad. I got grounded forever for that. So I stopped smoking until I got into high school. Then I started using almost every day and started to skip school with my friends that also used marijuana. I ended up failing all of my classes my 9th grade year. I also ran away a lot when I was in high school, so my parents put me on a program called Youth at Risk. So every time I ran away or got a dirty UA, I would get put into juvie for about a week or two. As I got older, I couldn't get a job because I couldn't pass a UA. And I was homeless for a long time, for the past 3 years, and I finally decided that I need to stop using marijuana. Marijuana has messed up my life enough. So I ended up moving to Spokane with almost nothing so I could get a fresh start at a brand new life. I moved into the homeless shelter and started to look for a new school so I could get my GED. I'm now about to start my NAC training and getting into my own place with my fiance and my 2 stepkids. I've been clean for 7 months, and it's amazing how much you can do once you put your mind to it.
There are also some social effects you might not be aware of, like developing antisocial behavior, causing problems among your friends and family. Your school performance can decline and increase the chance of dropping out. You will have greater chances of being unemployed and not being able to get good jobs, and also at risk of being less satisfied with life.
You can help by educating the 52% of 8th graders that do not know the side effects of marijuana. I have smoked marijuana since I was 9 years old. Now I'm 19, that's 10 years of use. The reason for starting was my peers around me, and my siblings also participated. I had access to this drug at a young age through my father, from about 9 to 15. I started to sell at 16 to get gas money, and that was what impacted my education the most. I started playing football in 7th grade and I loved it. The last year I played was 10th. That last half of 10th grade
is when I sold the most. And because I was busy doing that, I didn't make time for homework or class assignments. That caused me to fail some classes. So my junior year, I couldn't even play football. Since football was the main reason I even came to school anymore, I ended up dropping out. Lost contact with all my high school friends. Sold marijuana until I was 18. But on October 1st, 2016, I was going to do the usual sale of about 2 ounces. So to me, that was $260. But the buyer had a different plan. Jumped into their car outside my house, and it was gonna be a quick sale, but they say, let's go around the block. All I thought was they were trying to be safe. So 2 blocks away, they pull over, they rob me at gunpoint. That's not all they did. They beat me up with a gun, and since there was 3 against me, they all got their punches and left me in the middle of the street. I slowly made my way back home to get help, but I ended up in the hospital with 5 stitches in my head and bumps and bruises all over my face. If I knew I would end up in that situation, I would have never started selling. This is a topic I will talk to my daughter about when she is older as well. I will let her know my experience and how it impacted my life.
My life was better without it.
It's not worth the health or the legal risks.
Do your brain a favor and wait until you're at least 21 to smoke marijuana.
My life improved so much more after I stopped using marijuana.
There are so many other activities you could do besides smoking marijuana.
After my experiences with marijuana, I really think that you'd want to wait until you're 21.
84% of Washington teens do not use marijuana regularly.
Do we have any questions for our folks up there on our video?
Good job.
Yes, outstanding. Thank you guys for your work, and thanks for sticking around.
Thank you.
So that brings us to item number 9, which is our board member check-in. Lori? Susan?
Nothing.
Chuck?
Nothing.
Josh? Mike?
Keep the trend, nothing.
I have nothing as well. So based on what everybody has said here today, we will be having our next regular meeting will be on July 27th. We will have a quorum, so we look forward to seeing you all then. At this time, meeting is adjourned.